Welcome back, everyone, and welcome to our next session titled Empowering the Journey: How ctDNA-MRD Delivers Personalized Cancer Insights. And joining us today is Sorana Ursu. Sorana is a medical science liaison in the oncology division at Natera, providing medical education and clinical trial support to healthcare professionals. Previously a board-certified oncology pharmacist with over 10 years experience in hematology and stem cell transplantation, committed to advancing evidence-based care to improve outcomes for patients with cancer. It is with tremendous honor I am happy to pass the floor to Sorana. Thank you so much for being here with us today.
Yeah, thank you for having me. I feel very honored to be able to present our data on circulating tumor DNA to your group today. And hopefully you all will be able to take away information to feel empowered in your own cancer journeys. Okay, let me go ahead and share my slides and we'll go ahead and get started. Okay. Can everyone see them? Yeah, okay, we'll go ahead and we'll get started. So to set the stage, I first wanted to introduce where circulating tumor DNA or Signatera test fits into the patient care journey, because there's different technologies out there, and it's important to know where circulating tumor DNA fits in terms of residual disease detection. So you can have different technology in terms of comprehensive genomic profiling, where you're selecting targeted therapies or targeted chemotherapies based on certain mutations that are found in that tumor. And that's what's known as comprehensive genomic profiling, which is the bucket on the right, cancer therapy selection. The other part that you can use technology in order to do genetic testing is for hereditary cancer genes, or genes that may be passed down from mom and dad to the patient, and then those will put a patient at an increased risk for cancer later on. That would be known as hereditary cancer screening, which is outside of where circulating tumor DNA falls in. Circulating tumor DNA falls in the applications of being able to detect residual disease, be used for surveillance for early recurrence monitoring to see if the cancer is returning sooner than we might see on imaging or standard conventional tools, and then also be used for treatment response monitoring. So that's what the talk is going to be focused on today. So before we move on, what exactly is circulating tumor DNA and how do we use it? In your body, you have normal healthy cells that will grow, divide, and die off. When that happens, you'll have tiny fragments of DNA that are released into the blood, and that's known as cell-free DNA. This same process that happens in healthy cells also happens in cancer cells as they're growing, dividing, and then eventually dying off. And when they release tiny fragments of DNA in the body, that's known as circulating tumor DNA because it's a specific to that tumor or that cancer type. You need a very sensitive and specific assay in order to pick up those tiny fragments of DNA that are floating in the blood. And what makes circulating tumor DNA a nice biomarker is it has a short half-life, meaning that it can provide you a real-time assessment of what's happening in that body, giving you a certain snapshot in time. Natera is a leader in cell-free DNA technology. The company was established in 2004, where we initially developed technology where we were able to detect the differences between babies' DNA and maternal or mom's DNA in order to detect genetic abnormalities through non-invasive prenatal testing. That was our initial product known as Panorama. Since then, we've taken that technology and developed it and expanded it into oncology and also into organ health. And since then, we've launched 9 new products and entered 2 new markets. The way that the Signatera assay that detects circulating tumor DNA is built is that we really take a truly personalized and unique approach. It's not a one-size-fits-all test. We custom design an assay specific to the patient's unique tumor signature, or known as a fingerprint of that cancer. So we'll take tissue and also matched blood at the same time, and we'll do whole exome sequencing. So we'll sequence the genes that are present, and we're looking for certain mutations. The reason that we also get a sample of matched blood is because when we do the sequencing for that, we'll also filter any germline mutations to make sure that what we're tracking is specific to that cancer or tumor type. From there, we'll custom design the assay specifically and unique to each patient. And the types of mutations that we track are clonal mutations, which I'll get into what that means in a little bit. In order to initially design the test, it takes about 4 weeks because we use tissue. After that, it's a simple blood draw, and it'll only take about 7 days in order to get those results in terms of a turnaround time. And then subsequent blood draws will be able to detect the presence or absence of circulating tumor DNA over time. And here's a graphical representation showing the types of mutations that we track. So when we say clonal mutations, they're mutations that happen very early on when the cancer develops and is present and growing. So we're not tracking driver mutations or mutations that you may target with chemotherapy, because those can go away or come back depending on the types of treatments that a patient is being given. So those are not mutations that ideally you would want to track. By tracking these clonal mutations that happen early on, it allows the blood test, to be very sensitive, specific, but also maintain longevity over time throughout the patient cancer journey, because we'll be able to track those mutations over time. This is what a Signatera sample report looks like. It's 1 page, easy to read. At the top left, you get a Signatera negative or positive. In the middle top, you get an absolute measurement or a number of what that circulating tumor DNA is, and that's reported out in mean tumor molecules per milliliter. So you're able to track that number over time. You get a graphical representation of what the results look like, and then all of the numbers reported out here with the date of the blood draws. And then, since Signatera is a personalized and unique assay to each patient to that particular cancer type, what we see is that we can pretty much design an assay for any cancer type. And when we do that, we see strong and consistent performance across a variety of different cancer types, as seen here. High specificity, high sensitivity. That median lead time that you see under those graphs of several months, what that means is that Signatera, or circulating tumor DNA, is so sensitive that it can pick up molecular recurrence or microscopic disease in the blood several months before it's found on imaging. And what we see here is, what is a circulating tumor DNA telling you? Well, what it shows you here is that if you're ctDNA positive in blue, these patients are at a higher risk of having disease relapse than those patients who are ctDNA negative. So being ctDNA is a good thing, and that's something that we would want to see. And you can use this information in order to have those conversations with your providers as well. This graphically displays over the now actually 150 publications that we have with Natera across a variety of different cancer types. Again, highlighting how extensively validated the assay is on real patients as part of clinical trials and real-world data. Most of our data is in colorectal cancer space, and since then we've expanded to other tumor types as well. Now we'll go ahead and shift into moving into the management of colorectal cancer and some of the challenges that are seen today. So some of the challenges that patients may face is being able to identify which patients truly benefit from adjuvant therapy and being able to identify the patients that are at the highest risk of recurrence or their cancers coming back. And current monitoring tools have their own limitations. So for example, biomarkers like CEA that you may be familiar has its own limitations because they can fluctuate or change outside of cancer reasons. And imaging has its own limitations on being able to pick up the disease. And that's all where areas and opportunities where circulating tumor DNA can help come in and fill in that gap. Here are some of the clinical applications for circulating tumor DNA in different stages of treatment of where a patient may be. So early on, this area before surgery, or what we call the neoadjuvant setting, you can use circulating tumor DNA to determine if the treatment is working. After surgery, or in the adjuvant setting, you can help identify which patients would be most likely to benefit from adjuvant therapy and those that would be at the highest risk for relapse. After finishing treatment and going into surveillance, you would be able to use circulating tumor DNA to see if the cancer is coming back earlier than what we may see on standard tools such as CT scans. And then the relapse setting, when patients are in treatment, using it for treatment response monitoring. So the questions that we're really trying to help answer here that will help the patient are, do I need additional therapy? Is the treatment working? And is the cancer coming back? Here's another graphical representation of those buckets of where circulating tumor DNA can be used, all the way from before surgery, after surgery, in surveillance, and then treatment response monitoring. And that's what the talk will focus on today and the data that we have to help support these areas. Okay. So let's move into the first section. One of the questions that patients may ask is, do I need additional therapy? So what are some of the current clinical management that patients with stage 2 and 3 colorectal cancer face today? Well, for stage 3, we know that current guidelines recommend treating all patients with adjuvant chemotherapy. However, we know that more than 50% of patients are cured by surgery alone. So does that mean that there's a certain group of patients that we may be over-treating here because some patients may have good outcomes with surgery alone? For your stage 2 colorectal cancer patients, standard of care chemotherapy here is optional, and it really depends on that conversation with you and your provider and other high-risk features. However, we do know that a certain group of patients have a higher risk of recurrence, up to 20%. So we want to make sure here that we are treating the right patients who are at that higher risk of recurrence. And these are all areas where circulating tumor DNA can come to help inform and be used as an additional tool by a blood test to help make some of those decisions as you're having conversations between patients and physicians. So what we do know is that if you're circulating tumor DNA negative, you have a better prognosis in terms of outcomes. And if you're circulating tumor DNA positive, those patients have poorer prognosis or poorer long-term outcomes. So here we can use circulating tumor DNA as an opportunity in order to be more selective in how patients are being managed in the adjuvant setting. Now I'll get into reviewing some of the data that we've had published in Nature Medicine. So first, I'd like to focus on a Galaxy study, which was published twice in Nature Medicine. Now we have an even larger cohort of patients with an even longer follow-up of 3 years. So looking at the Galaxy study, Galaxy was a large observational study that included colorectal cancer patients with ctDNA collected throughout. So this is an observational study, meaning patients were followed throughout and then their outcomes were monitored. ctDNA was collected 1 month after surgery, so in that post-surgical window, 3 months after surgery, and then every 3 months up to 2 years. Galaxy was part of Circulate Japan, which included 2 other interventional studies based on ctDNA negativity and ctDNA positivity, but I won't get into those today. We'll just focus on Galaxy. And we'll go ahead and we'll break this slide down into the outcomes that we saw from that observational study. Here we had a large cohort of patients where we analyzed the data from about 2,100. And we looked in the MRD window, which is defined as 2 weeks after surgery, but up to 10 weeks before the start of any adjuvant therapy. And when we look at what circulating tumor DNA tells us, is if we look here on this graph on the left, patients who were ctDNA positive in blue, they had worse disease-free survival than those that were ctDNA negative, meaning that if you were ctDNA positive, you were 12 times more likely to have disease recurrence than ctDNA negative. That was for all stages. We see a similar trend for high-risk stage 2 and 3 colorectal cancer patients on the right. When we look at overall survival outcomes, we see a similar trend compared to disease-free survival. So here, if you were ctDNA positive, you did worse than those who were ctDNA negative. And that's reflected for all stages right here in this 36-month overall survival. We can see if you were ctDNA negative, these patients had 96% overall survival compared to about 72%. So what this is telling us is that from a single blood test following surgery, we're able to tell which patients will have better long-term outcomes and which patients will have worse outcomes. One of the next questions that the study went on to answer is, given what we know about adjuvant chemotherapy recommendations being administered for high-risk stage 2 and 3 patients only, can we use circulating tumor DNA as a blood test to really define which patients will benefit the most? And if we first look on the right here, if you were MRD window positive, meaning circulating tumor DNA was positive following surgery, we see that patients who got adjuvant chemotherapy or were treated in green had improved outcomes compared to those in blue who did not receive treatment or were just on observations alone. So there's a nice separation of the curves, and we can see the patients being treated with chemotherapy following surgery had a significant benefit. On the left, if you were MRD window negative or your circulating tumor DNA was negative following surgery, we don't see a significant benefit in giving these patients adjuvant chemotherapy versus observational alone. And you can see that with the 24-month disease-free survival hovering about 89% in these two groups. So how can you use this information? Well, one, right, if you're ctDNA negative, can we potentially spare all of the side effects that may be happening from these chemotherapy and going on to surveillance alone? That would be a conversation to have with your physician as part of shared decision making. And then if you're ctDNA positive, those would be the patients that we would want to give chemotherapy with because we do see that benefit. So what circulating tumor DNA is telling you is that it's a blood test that will give you more information in order to have those conversations with your physicians when you're coming up to make these decisions of should I get treatment or not. Another way Signatera or circulating tumor DNA is being used to identify patients who may benefit from additional interventions was highlighted in the CalGB SWOG 80702 study. This study included stage 3 colon cancer only patients, so a little bit different patient population than the study we just looked at. And here all comers got adjuvant chemotherapy. The intervention was whether you got celecoxib on top of that or not. And in this analysis, if we break down this graph here, we see that for the ctDNA positive group right here, If you were ctDNA positive and you got adjuvant chemotherapy with celecoxib, you had improved survival outcomes compared to if you were ctDNA positive and you got adjuvant chemotherapy alone. That's where this 42% improvement in overall survival comes from. And we did not see that effect in the ctDNA negative group. So this data is showing you that for patients who are circulating tumor DNA positive only, adding celecoxib in addition to standard of care adjuvant chemotherapy showed a significantly and clinically meaningful difference in terms of improving patient outcomes. I won't go through the list of all of these studies. I wanted to include this slide to highlight all of the ongoing ctDNA guided clinical studies that are out there, and Natera's heavily investing back into research to help answer these questions for patients. Okay, so moving through the patient cancer journey, you started adjuvant chemotherapy. Now, is there anything else that can tell us how treatment is working outside of scans, right? Is there an opportunity here where we can use a biomarker blood test like circulating tumor DNA to help determine treatment response? And what we've seen from our data, this was a study of patients with advanced stage disease who were receiving immunotherapy, and this group was pembrolizumab. And ctDNA was collected very early on at baseline and then 6 weeks into treatment. And what we see is that when you follow ctDNA levels, it can tell you outcomes. So for here on the left, if your ctDNA level is decreasing in blue, these patients have significant improved progression-free survival and overall survival compared to patients who have ctDNA levels that increase. So here we can tell very early on, 6 weeks into treatment, which is about right before cycle 3, day 1 starts of immunotherapy, whether patients will benefit from treatment or not. And again, this is showing as early as 6 weeks, increasing levels in ctDNA predicted a lack of response to pembrolizumab. And at this point, 98% of patients who had increase in levels by the start of cycle 3, those patients did not go on to achieve an objective response. We can also look at whether the ctDNA levels are clearing. So what that means is that you were positive and then you turned negative and then you stayed negative. That's how we define ctDNA clearance. And what the study showed us is that if you cleared your ctDNA and remained negative, this top blue line, those patients had excellent outcomes, 100% overall survival at a follow-up about 2 years. However, the patients who had ctDNA levels that were still present or continued to rise, those patients did not do as well. And then when we go on to look at those changes in ctDNAs, meaning that, right, you have 3 trends you could have with your ctDNA. Your ctDNA positive, your ctDNA negative, or then sometimes your levels can be positive, they go back negative, you cleared, but then you turn back positive again, right? So that transient clearance. What this graph here is showing us is for colorectal cancer patient, 96% of patients who converted to ctDNA positivity by 18 months here. And we saw that peak conversion of when patients converted to ctDNA positivity at about 6 to 9 months. So why is that important? Well, that's usually the typical time when patients will be completing adjuvant chemotherapy. So it's important to catch patients that may be turning ctDNA positive who were previously ctDNA negative as they're finishing up their chemotherapy. So this highlights the importance of repeat testing of ctDNA instead of just a single time point, because you want to be able to catch ctDNA that may be turning positive. Okay. So now moving through the patient journey, you finished adjuvant therapy or your chemotherapy regimen, and now you're in surveillance. And you want to help answer the question, is the cancer coming back? You may be familiar with CEA as a biomarker if that's already being ordered by your physician. And what here we look to show is how does ctDNA compare to another biomarker that is available for colorectal cancer patients. And what we saw here is that if you look at ctDNA in the bars on the left, for stage 2 and 3 colorectal cancer patients, ctDNA is much more sensitive as a biomarker with sensitivity at 92 and 90% for stage 3 compared to about 37% and 48% with CEA. And that makes sense if you think about the way that we design the blood test is that we're designing it off of tumor tissue that's specifically identifying mutations present in that patient's particular cancer type. So it's a much more sensitive way of tracking the cancer. And then when we look at how circulating tumor DNA compares to catching recurrence that may be seen on conventional imaging, such as scans, we see that Signatera is much more sensitive in catching that lead time. That lead time is meaning that we're able to detect microscopic disease several months before it's being caught on scan. The average lead time that we've seen for colorectal cancer patients is about 8.7 months, but it can range up to about 16 and a half months. So this gives you an extra window of opportunity to have those conversations with your physician, about what next steps are and what the plan is in place. Additionally, what we see is that circulating tumor DNA can be used as a biomarker in surveillance as well. So here, again, ctDNA positive in blue, those patients are 20 times more likely to go on to have disease recurrence than patients who are ctDNA negative. And this is in the surveillance setting. In this particular patient group for colorectal cancer, 188 patients had disease recurrence. Signatera was positive 86% of the time. And out of the patients that were Signatera positive, 30% went on to go and receive oligometastatic directed therapy. So what that means is that the physicians were able to intervene either through surgery or ablation to remove that metastatic site of where that cancer came back and give patients a second chance at cure. I think one important part that clinical trials and studies don't do enough of is reporting patient outcomes. So that was one thing that we really wanted to make sure we had with a different study, which was Bespoke CRC, which is our first large United States-based trial across about 100 sites in the United States for colorectal cancer stage 2 and 3. Circulating tumor DNA here was drawn before surgery, after surgery, and surveillance. But the important part that I want to highlight here is that we included patient-reported outcomes throughout. And an optional survey was provided to the patients that was collected at the time of enrollment and at those set intervals throughout. And what we see is out of the 413 patients that filled out the survey and provided answer, it was overwhelmingly positive of their view of how they perceived circulating tumor DNA as part of their care plan. About 3/4 of patients reported ctDNA reducing anxiety about their cancer coming back. 87% of patients felt that they were receiving the right treatment after getting their results. And then over 90% of patients would continue using ctDNA, and 96% of patients valued that additional information that circulating tumor DNA provided. So if you can see here, I would say that these were very positive results, and patients valued the information that they received in terms of feeling more confident about their care, valuing the information that they got, and helping to ease fear and anxieties that may come from the treatments, and wondering if your cancer is coming back or not. So how do you have access and how can you order this test? Signatera is available across Canada through Life Labs. In British Columbia and Ontario, you can order online directly from the website, and anyone outside of those provinces can order by calling Life Labs Genetics. Here is the ordering guide. So step one, you would complete your requisition. The patient would fill out the first section, including your signature. The physician would complete sections 2 to 5. Step two, you would purchase Signatera. Step three, you would receive your blood kit. Step four, do the blood sample collection. Step five, receive your results. This is what a Signatera order requisition form looks like. Again, that first section is where you would fill out the patient information. The following sections would be filled out by your physicians. I do want to conclude the talk today by presenting a couple of case studies because I think it's important to see the applications of this blood test, circulating tumor DNA, in real world patients. So the first case study is a patient who had T3N0 colon adenocarcinoma or stage 2 colon cancer with high risk features. This patient was started on adjuvant chemotherapy. So how can we monitor this patient for early recurrence? Well, we can use serial monitoring or repeat testing of circulating tumor DNA. Here is a graphical representation of what happened to ctDNA levels throughout this particular patient's treatments. So we have ctDNA on the left, and then the months from surgery on the horizontal axis. So the patient was initially ctDNA positive following surgery, was started with adjuvant therapy here, Zelox. Patient cleared their ctDNA, meaning that ctDNA was positive, turned negative while on treatment, stayed negative, and then went into surveillance. Patient continued to test Signatera ctDNA negative, and here at about 14 months, ctDNA popped up positive again. As a result, here the physician increased the frequency of CT scans and then considered an escalation to a PET. A Signatera ctDNA level was repeated that was positive and continued to rise. At that time, there was a 2 centimeter lesion found in the liver by CT scan. And then the patient underwent radiofrequency ablation with curative intent, cleared their ctDNA, meaning the ctDNA turned negative, and then stayed negative on that repeat sample. And the patient remained disease-free at 2 years follow-up. So again, this highlights of where repeat testing can be used in the adjuvant setting and in surveillance. And here, the ctDNA level was used with the physician to help increase the frequency of scans and actually caught something by a liver lesion, and then the physician was able to act on it. Okay, and then I will show this patient video, and then that will conclude the presentation. So let me see if it will load up now. 1 second. I may have to share my screen again, so 1 second.
Well, I think we're having some issues, Sorana, and just conscious
Oh.
of time, I think maybe we will say thank you very much here. I do apologize for those technical difficulties. It is truly a popular conversation, and we thank you very much for bringing that to us today. Uh, Moving forward, our silent viewers can now head back to the lobby until the next session, which will take place after a quick additional 15-minute health and stretch break. And we'll reconvene at 12 p.m. Eastern Time for our next session with Dr. Lukovic. Our coaches will now head backstage for their discussion period, and we will see everyone at 12 p.m. See you soon.